Okay, good evening, guys. Thanks for coming today for this second meeting. We hope to see you every time in this number. We hope you will enjoy this presentation, and now I'll leave the floor to Floriana, which will introduce you the presentation.
So today we have a special guest from the Pancreas Clinical and Translational Medicine in San Raffaele Hospital, Dr. Valentina Andreasi. So she's going to present total pancreatectomy with islet autotransplantation as an alternative to high-risk Pancreatojejunostomy, a prospective randomized trial. So enjoy. Grazie ancora per essere venuta.
Thank you. So good evening, everybody. So currently I'm second year resident here at San Raffaele in general surgery, and I did a PhD before here in San Raffaele, and I worked on pancreatic surgery and pancreatic neuroendocrine tumor. And today I'm going to talk about a recent paper that was published recently on Annals of Surgery, which regards a hot topic in the setting of pancreatic surgery, which is the management of a very potentially severe complication, which is pancreatic fistula. So just a brief introduction regarding pancreatic surgeries, because I think that okay. So I think that there's quite an audience, and maybe not everybody is into pancreatic surgery. So I will briefly introduce everything. So regarding pancreatic surgery, we have different kinds of pancreatic resections. We have the formal resections, which include pancreaticoduodenectomy, distal pancreatectomy, and total pancreatectomy. And we will focus on these resections today. And then we have the parenchyma-sparing resections, which are, for example, enucleation and central pancreatectomy, which have the main advantage of reducing the functional problems related to diabetes or exocrine insufficiency. But usually when we talk about pancreatic cancer, they are not used, and we prefer the formal resections, which are associated with more extended lymphadenectomies. So today we will focus on two of these formal resections, which are pancreaticoduodenectomy and total pancreatectomy. So pancreaticoduodenectomy is one of the most frequently performed pancreatic resections. And essentially, we remove the pancreatic head, the duodenum, which cannot be dissociated from the pancreatic head, the gallbladder, part of the bile duct, and the associated lymph nodes. And then we have three anastomoses. So the first one is the duodenojejunostomy or gastrojejunostomy, according to the chosen technique. Then we have biliojejunostomy, and then we have the pancreaticojejunostomy, which will be the focus of this presentation and the main problem in the setting of pancreatic surgery. And then we have the other pancreatic resection, which is total pancreatectomy. In this case, we remove the whole pancreas. If we talk about cancer, we remove also the spleen in order to guarantee and to be oncologically adequate. And then the duodenum, the gallbladder, part of the bile duct, and again, the associated lymph nodes. And in this case, of course, we have just two anastomoses, which are the duodeno or gastrojejunostomy and the biliojejunostomy. Of course, we do not have any pancreatic anastomosis because the pancreas has been removed. So pancreaticojejunostomy, as I was saying before, represents the most critical anastomosis because adhesions of these anastomosis determines the development of one of the most potentially severe complications in the setting of abdominal surgery, which is postoperative pancreatic fistula. So according to the most recent definition, clinically relevant postoperative pancreatic fistula is defined as a drain output of any measurable volume with an amylase level, which is at least 3 times the upper limit of the normal serum amylase level. And it is associated with a clinically relevant condition that is directly related to postoperative pancreatic fistula. And we have essentially 3 levels of severity of postoperative pancreatic fistula. We have the biochemical leak, which essentially has no impact on the postoperative course of the patient. And then we have grade B postoperative pancreatic fistula, which is considered clinically relevant. And this is a fistula that is treated with medical measures, endoscopic measures, or radiological procedures. And finally, we have grade C postoperative pancreatic fistula, again, a clinically relevant complication. And in this case, we need a reoperation, a single or multiple organ failure, or even death to define this grade of pancreatic fistula. So clinically relevant postoperative pancreatic fistula occurs in approximately 10 to 33% of cases. This is quite a wide range, and it depends on the theories that we consider in the literature. And it is the major determinant of morbidity and mortality after pancreaticoduodenectomy, as you can see in the graphs reported here. So it is responsible for 22% of organ failures, 26% of mortality, and so on for hospital stay and readmission. So are we able to predict preoperatively the risk of postoperative pancreatic fistula? Yes, partially, because we have a number of fistulary scores that have been developed over the years in order to predict the risk of this complication. Here we have some recent articles that have been published on important journals. But the most used fistulary score is the one developed by Callery almost 10 years ago. And the four most important parameters that are usually considered to define the risk of developing postoperative pancreatic fistula are the pancreatic texture. So it can be firm or soft. If we have a soft pancreatic texture, the patient has a significantly higher risk of developing a postoperative pancreatic fistula. Then we have the pathological diagnosis, because patients with adenocarcinoma or chronic pancreatitis usually have a more fibrotic pancreas, and so their risk of developing postoperative pancreatic fistula is reduced compared to patients, for example, with 60 tumors or neuroendocrine tumors. And then we have the diameter of the main pancreatic duct. So the smaller the diameter of the duct, and the higher the risk of developing a pancreatic fistula, because if you have like 1 millimeter pancreatic duct, of course, the anastomosis is more difficult to be performed, and of course, the risk of developing adhesions is higher. And then we have the intraoperative blood loss. So the higher the intraoperative blood loss, the higher the risk of pancreatic fistula. So are we able to avoid postoperative pancreatic fistula? No. There are a number of measures that have been tried over the years, but actually the rate of postoperative pancreatic fistula remains in the range that I showed you before, so between 10 and 35%. So desperate times call for desperate measures. We have a measure to prevent at all the occurrence of pancreatic fistula, which is total pancreatectomy. The problem is that total pancreatectomy currently is not considered as a valid alternative to pancreaticoduodenectomy because it has very important functional outcomes, and it is related to a very bad deterioration of the quality of life, because we have on one side the development of pancreatic exocrine insufficiency, but the biggest problem is represented by the brittle diabetes, because we have a diabetes that is related not only to the lack of beta cells, but we have also the lack of alpha cells. So it is more difficult to be controlled, and the patients frequently experience a lot of episodes also of hypoglycemia. So it can be really bad, and sometimes patients are also readmitted to the hospital because of problems related to the control of diabetes. So after this, and over the years, however, especially in the high volume centers, the perioperative outcomes and also the quality of life of total pancreatectomy have improved, but we're still not at the point of considering total pancreatectomy as a possible alternative to pancreaticoduodenectomy. And so after this introduction, we come to the article that is the topic of today's presentation. So total pancreatectomy with islet autotransplantation as an alternative to pancreaticoduodenectomy for patients considered at high risk for pancreatic fistula. So we have already talked about the 2 pancreatic resections that are considered in this article, pancreaticoduodenectomy with a risk of pancreatic fistula and total pancreatectomy, where we remove this risk at all. And then we have the islet autotransplantation. So in the islet autotransplantation, essentially, we have the pancreas that is removed. Then the islet cells are isolated. And the islets then are injected with a percutaneous procedure into the portal vein. And the beta cells from now on will be in the liver, and they will produce insulin at this level. This kind of transplant, of course, it is an autotransplantation, so we do not need immunosuppression. And essentially, it facilitates the control of glucose metabolism after pancreatectomy. So who are the candidates for islet autotransplantation? This is another debated issue. So these Minnesota criteria are the criteria that were valid some years ago. So essentially only patients with chronic pancreatitis or relapsing acute pancreatitis were considered for islet autotransplantation. And they also had need some functional criteria. So they should be patients with chronic or recurrent acute pancreatitis with a significantly impaired quality of life, unresponsive to medical or endoscopic therapy, and pancreatic cancer represented a contraindication. Nowadays, we have the so-called Milan Protocol, and essentially the indication for the islet autotransplantation has been extended also to malignant and borderline lesions. So we consider the islet autotransplantation, of course, in patients with chronic or recurrent acute pancreatitis, but also in patients with high-risk pancreatic stump, in patients who undergo an extensive distal pancreatectomy, and in patients with severe complication, especially postoperative pancreatic fistula after pancreatic surgery. So this is just a picture which shows the strategy for minimizing the risk of spreading tumor, because if we consider also patients with pancreatic cancer for the islet autotransplantation, the problem might be that some cancer cells are within the tissue that we decide to use for the islet autotransplantation. So we have several safety levels. So the first one, patients with multifocal disease are excluded from the islet autotransplantation because it would be too risky. Then, of course, we need that the pancreatic margin that we resect is negative for cancer cells. And we need at least 1 centimeter of pancreatic tissue that is free of cancer cells. And then we have a purification step. And finally, another level, which is not mandatory, which is a detection of contamination from cancer cells. After all these steps, it is quite safe to perform islet autotransplantation also in patients who have a pancreatic cancer, of course, in another part of the pancreas and not in the one that is used for the islet autotransplant. So the main aim of the present study was to investigate prospectively the role of total pancreatectomy with islet autotransplantation in patients candidates for pancreaticoduodenectomy and at high risk for pancreatic fistula. So the main hypothesis was that total pancreatectomy with islet autotransplantation is associated with lower morbidity compared to pancreaticoduodenectomy with the Pancreaticojejunostomy in patients who have a soft pancreas and a small pancreatic duct. So in this study, only pancreatic texture and diameter of the main pancreatic duct were considered as parameters to define the risk of postoperative pancreatic fistula. We have seen before that there's a score that is used in the clinical practice, which is the calorie score, the one considering 4 parameters. But the problem is that the present study started before the publication of that score. So only these 2 parameters were used to define the patients at high risk of postoperative pancreatic fistula. And so this is a prospective randomized study. It was developed at 2 centers, here at San Raffaele and from 2013 also at the Humanitas Hospital. And the time period was from 2010 to September 2019. As inclusion criteria, we have age older than 18 years, a fasting glycemia below 126. So patients that were had diabetes before surgery were excluded from the study. And the main reason is that if we plan in one group to perform the islet autotransplant, of course, we cannot consider patients that are already diabetic because they have a reduced number of beta cells, and then the transplant probably would not work. So only patients without diabetes were considered. And the reason why we have 9 years of enrollment is that we have a lot of patients with pancreatic cancer who have diabetes before surgery. In most of cases, the patients becomes diabetic maybe 6 months or 1 year before discovering that there is a pancreatic cancer. So a lot of patients were excluded from this study because of this reason. And then the other preoperative criterion was a main pancreatic duct diameter below 3 millimeters, evaluated on CT scan. Inclusion criteria, the presence of multifocal neoplasms. As I was saying before, it will be too risky to perform an autotransplant if there's a multifocal disease. And of course, the presence of a positive resection margin at the intraoperative frozen section, again, for the same reason. So after this preoperative phase, so patient aged more than 18, duct diameter below 3 millimeters, and no preoperative diabetes, there's an intraoperative step. So the surgeon manually assess the pancreatic texture and measure intraoperatively the main pancreatic duct. If a soft pancreatic texture is observed and a main pancreatic duct of 3 millimeters or below is confirmed, then the patient was randomized. So we have 2 treatment groups. Group A is Pancreaticoduodenectomy with Pancreaticojejunostomy, so the standard treatment. And Group B is the total pancreatectomy with the islet autotransplantation. So in this case, total pancreatectomy was performed in the vast majority of cases as spleen preserving. In this case, the tumor was located in the pancreatic head because the patient was candidate to pancreaticoduodenectomy. So the reason why we remove the body tail is only for a problem related to the pancreatic fistula, not for an oncological reason. So in this case, we allow to leave the spleen in place without removing it because it is not an oncological reason. And then the islets were infused into the portal vein intraoperatively, but in most of cases within 48 hours with a transhepatic radiological portal vein infusion. So all the patients were followed for 12 months after surgery or until death. And the patients came at the outpatient clinic after 1, 3, 6, and 12 months. So the first endpoint was the incidence of postoperative complications within the first 90 days of surgery. And other endpoints that were considered were the incidence of specific complications, the length of postoperative hospital stay, the unplanned readmission, the incidence of endocrine and exocrine insufficiency, and then several oncological outcomes, of course, only for patients that had a cancer located in the pancreatic head or in the duodenum. So we started with 89 patients that were candidates for pancreaticoduodenectomy and were considered preoperatively as at high risk for pancreatic fistula. Then 28 patients were excluded at the time of surgery because, for example, intraoperatively, there was no soft pancreatic texture or the pancreatic duct was greater than 3 millimeters. And then finally, 61 patients were randomized. And we had 31 patients in the standard treatment group, so pancreaticoduodenectomy, and 30 patients in the total pancreatectomy with the islet autotransplantation group. From group A, 3 patients withdrew because due to technical problems intraoperatively, they underwent a completion pancreatectomy. And so they, were excluded from this group. And in group B, 1 patient withdrew because due to postoperative liver hypoperfusion, no islet autotransplantation could be performed after surgery. So regarding the islet autotransplant, all the islet preparations in the study were considered as adequate for the transplant, and the liver was the site of transplantation in the vast majority of cases. The other possible site is the bone marrow. There were procedure-related complications in 5 cases. So in 4 cases, it was a bleeding, sorry, there's a spelling mistake, related to the transhepatic access. And in 3 cases, it was like a minor bleeding, but in 1 case, it was a severe one, and the patients had also an hemothorax. So it was quite a complex condition. And then 1 patient had a portal vein thrombosis that was solved with heparin. So regarding the general features of the population between the 2 groups, there were no significant differences except for a higher age in the group of total pancreatectomy. And regarding postoperative complications, the rate of complications was significantly lower in patients who underwent total pancreatectomy. If we consider the morbidity rate, so every kind of complications that patient had, in group A, which is pancreaticoduodenectomy, 90% of patients had at least 1 complication, compared to 60% of patients in the group of total pancreatectomy. And this difference is, again, statistically significant if we consider the patient who had at least 2 complications. So 74% in patients who underwent pancreaticoduodenectomy compared to 36% in patients who underwent total pancreatectomy. And then if we consider just the abdominal complication, again, we have a huge difference between the 2 groups. So the postoperative morbidity is significantly reduced in patients who undergo total pancreatectomy with islet autotransplant compared to patients who undergo pancreaticoduodenectomy. If we look at the severity of postoperative complications, we actually confirm the same data. So the complications that are graded as 2 or more are significantly higher in patients who underwent pancreaticoduodenectomy. And again, there's a trend, even if we do not reach the statistical significance, if we consider the complications graded as 3 or more. This grading of postoperative complications is made with the Indoclavian classification of postoperative complications, and essentially, so grade 2 complications are those treated medically, so antibiotics or also transfusions. And from grade 3, we have an interventional procedure that can be endoscopic or radiological. And then in grade 4, for example, we have a single or multiple organ failure. And then grade 5 is death due to postoperative complications. And then looking at the oncological outcomes, so there were no statistically significant differences between the 2 groups when overall survival, disease-specific survival, and disease-free survival were considered. But if we look at these graphs, you can see that the blue line, which represents total pancreatectomy, is always a little bit higher compared to the red line, because there's a trend towards a lower mortality in patients who underwent total pancreatectomy. And this can be explained by the fact that patients with pancreatic cancer who undergo pancreaticoduodenectomy and then experience a severe postoperative pancreatic fistula maybe wait for months before starting an adjuvant treatment. Or maybe they're not able to start an adjuvant treatment because of their general conditions related to the fistula. On the other side, if the patient undergoes a total pancreatectomy and has no fistula, then he or she can start the adjuvant treatment before, and this can lead to an improvement of survival in the long term. So in this case, it's just a trend, and this is just an hypothesis. So of course, we need further studies to demonstrate this, but this could be another important point for total pancreatectomy to be performed in patients that are at high risk for postoperative pancreatic fistula. And then looking at the functional outcomes, as expected, we observed that total pancreatectomy was associated with a significantly higher risk of diabetes and also a significantly higher risk of insulin dependency. Here you see the blue line. These are the patients who underwent total pancreatectomy, and almost all of them, except for one patient, developed diabetes. So they underwent the islet autotransplant, but almost all of them developed diabetes. So it was quite disappointing. And the patient who underwent pancreaticoduodenectomy, of course, had diabetes in a lower percentage of cases. But patients who underwent total pancreatectomy with islet autotransplant had actually a good metabolic control of their diabetes, a better control compared to patients who usually undergo total pancreatectomy alone. Because, as I said before, patients who undergo total pancreatectomy by itself, they have a brittle diabetes with a lot of problems of hypoglycemia. And in this population, where patients with total pancreatectomy had also the islet autotransplant, there were no problems related to hypoglycemia. So it was a diabetes that could be controlled, in some cases also without insulin. And so coming to the conclusions of the presentation and of the study, we have seen that total pancreatectomy is actually associated with a reduced postoperative morbidity compared to the standard treatment, which is pancreaticoduodenectomy. And that total pancreatectomy, of course, harbors a significantly higher risk of diabetes, even if we associate the islet autotransplant. However, the metabolic control seems to be improved compared to patients undergoing total pancreatectomy alone. The oncological outcomes are comparable if we look at the statistical analysis, but as I just said, there seems there's a trend towards a better survival in patients who undergo total pancreatectomy, and this is of course a point that should be further investigated in this setting. And finally, according to the results of this study, we could say that total pancreatectomy with the islet autotransplant might become, in the future, the treatment of choice in very well-selected patients who are candidates to pancreaticoduodenectomy when there is a high risk of postoperative pancreatic fistula. So thank you, everybody, for your attention. And quickly, if you have questions.
Guys, do you have any questions? Okay. So she asked if before performing an islet autotransplant, we had also to evaluate the liver function. No, it's not necessary. I mean, we do not operate usually patients who have an impaired liver function. Sometimes it happens in patients with pancreatic head cancers that they have, for example, obstructive jaundice at the beginning of their history. And usually they're not operated in this condition, so they place a prosthesis or something, and then their function normalizes. So we routinely check the function before surgery, but it is not strictly necessary for the islet autotransplant.
I had a question about the site of transplant. Like, in which case the transplant is done in marrow and not into the liver?
So it was like extremely rare that it was done in the bone marrow. Actually, I've never seen it. But I think that it's in patients that maybe have some like anatomical problem in the liver, something that, I mean, impairs performing, for example, the interventional radiology procedure to inject. So in these cases, but it's really rare. I think that it occurred most frequently like several years ago. Now it's almost always in the liver.
During islet or transplantation, I suppose was one to triple these. What about the other side of the other consequence of pancreatectomy? So in this case, the digestive tract among those. Are those compensated by the transplant, or does that still be a problem?
Okay, so he asked, okay, I talked a lot about brittle diabetes, but of course there's also the other side, so the exocrine function. No, it is not compensated by the islet autotransplant. Function is a little bit easier to compensate because we have the pancreatic enzymes that are assumed with the food, and you can increase a lot the dosage without having side effects. Of course, there are some patients with problems also on that side, but usually it's more the diabetes causing problems to these patients and less the exocrine function. Mm-hmm.
Like, how do they practically follow for saying how does it happen?
Okay, honestly, exactly. I mean, it's a lot technical and it's not done by the surgeons. So exactly, I don't know. This is my, but I think that I mean they found a new environment where they can place and they form new areas where they where they are able to stay and survive, and I mean they just do not go away with the circulation. So there is also a treatment of these cells within the steps in order to make them stay. I think that in the article there's the detailed protocol also of this part, but honestly it's a lot technical and I never performed it. So. Okay, so he asked how if we are able to predict the pancreatic texture before surgery. So there are several studies because this is quite a hot topic. The problem of pancreatic texture evaluated intraoperatively is that it is very subjective. So the surgeon feels the pancreas and he says it's soft or it's firm, but I mean, it's really subjective. So we did a study where we correlated the texture evaluated as soft or firm with the composition of the pancreas, and usually a soft texture corresponds to a pancreas which has a high acinar content, so a lot of secreting cells, so higher risk of pancreatic fistula. On the other side, firm pancreas is more fibrotic, so the one of the patients with chronic pancreatitis or adenocarcinoma. So there are some studies that correlated the acinar content known at the histological examination with the preoperative CT scan. And there are some parameters at the basal CT scan and also in the portal phase that seem to correlate with the composition, acinar or fibrosis, and then so with the pancreatic texture. But these are, I think, like 3 or 4 studies with a very small sample size, so they're not into the clinical practice yet. But this is a very good point because the intraoperative evaluation of pancreatic texture is not a reliable measure. So I do not know about any cardiovascular problems. I mean, you can have problems of thrombosis in the vessel where you inject. We had one case, and we had in total 30 patients in that group. So 1 of 30 patients had that problem, and usually it is quite rare that we operate patients with portal thrombosis, and if we operate these patients, I think we would not candidate them for an islet autotransplant, because if you saw, there was the patients that were excluded. Okay, so patients that were excluded, so 6 patients were excluded from the randomization because they had a locally advanced and or metastatic disease. So locally advanced usually means that there's an involvement of vessels, portal vein, superior mesenteric artery, and you can have a direct infiltration or also thrombosis. And so in this case, the autotransplant would not be performed because there would be then a problem.
The risk of pancreatic fistula the same in the surgery that is robotic and
so yes, there are several studies that compare the usually. So here we talked about pancreaticoduodenectomy. Pancreaticoduodenectomy in most high volume centers is performed open. It is very rare with a laparoscopic approach. In some centers you can do it robotic. There are few studies comparing pancreaticoduodenectomy with the 2 approaches, but there is no significant difference in terms of pancreatic fistula. There are a lot of more studies regarding distal pancreatectomy, because distal pancreatectomy is usually performed with a minimally invasive approach, and there you don't see a significant difference in terms of pancreatic fistula. But of course, in distal pancreatectomy, the biology underlying the fistula is completely different from pancreaticoduodenectomy because you do not have an anastomosis. So the patient in the study were followed just for 1 year. Usually the islets last for 5, 7, 8 years. And in this study, we had, just take the slide. Considering the data at 1 year, there were 4 patients that had like functioning islets because they had an insulin independence. So their diabetes was okay just with oral medicine. And then we have 22 patients who had partial graft function. So they had insulin, but looking at the levels of C-peptide and insulin, they still had a function. And then 3 patients just at 1 year, they had no graft functioning. Of course, if we look at other studies, retrospective, for example, if we go on with years, the graft stops functioning. So it is a temporary benefit. But if we consider that maybe we have patients that are 70 years old, maybe you have a quite good control of their diabetes for about 10 years. And then, yeah, of course, you have the problem. No, I don't think so. I mean, they can be stored, but just for like 48 hours that to inject. But I'm not aware about long-term.
Any other question? Maybe I lost it, but does the transplant influence somehow the functional role? Like there are
No, no, there is not this kind of problem. I mean, the problem that you might have, we didn't have in this study, is that it is really rare that you inject like cancer cells. That could be the problem. I mean, we had one case of islet autotransplant that was like a side of this study. So it was an autotransplant and the patient had a neuroendocrine tumor. And we did the islet autotransplant. And in that case, so you inject the islet cells in portal vein. You can choose usually the right vessel, the right portal vein. And this patient developed like 15 months after surgery, liver metastases that were located only in the right liver lobe. So this you can have, it's really rare, but in that case, it was really,
sorry, this may be quite a far-fetched question, but did you have any instances of patients after the islet transplantation getting hepatitis?
No.
Or even like having viral hepatitis and then they have
Sorry, after the islet transplantation, when?
After, I mean, as you follow up the patient, by chance they contract viral hepatitis. Did you ever have this kind of instance? I was wondering what could happen if the liver has a disease.
No, we don't have this kind of data.
Okay.
No. No, it would be interesting, but I'm not even sure that they are routinely tested for hepatitis if there's not a contact. Because, for example, before surgery, patients are not routinely tested for hepatitis. So if you like sting or something, you have to request the test also on the patients because they're not routinely tested.
Any other? Sure. 100%? Okay.
Thank you very much for being with us today. Vogliamo fare una standing ovation? No standing ovation? No? Okay. Okay, guys, thank you for coming today. We hope to see you next time with our colleague Paolo, and which will be the first student to present. And have a good night.